All right. For the last of my neuro lectures, we're going to look at spinal cord injury. So, spinal cord injury is going to really start with the out of hospital setting. A lot of involvement with EMS and how they're transported to the hospitals. And then, really, when they get to us, we should just be carrying on with what is already happening for the client. So the biggest instance or the biggest example I want to give is just making sure that we have C-spine stabilization, that we're monitoring airway, breathing, circulation. Those are the biggest pieces that we probably need to address when we're looking to prevent further injury. Because you see that there's a whole process when we're looking from the primary survey, airway, breathing, circulation, that disability, and then the exposure. We have to assume that a spinal cord injury has happened, especially if we're talking about somebody who has fallen either from a high area, like on a roof, or maybe somebody who was involved in an electrical injury, so they got electrocuted, and we got to assume that they've fallen because of that. So again, C-spine stabilization, making sure that we have their spinal column in line, that we're rolling them using the log roll technique while providing some sort of traction. And generally, this is going to be true for most of our cervical or spinal injuries, unless it's a penetrating injury. So once we've kind of adapted that airway, breathing, circulation model, we're going to move into the overall neurological assessment, and that's the focused. So it's going to be LOC, and we're going to look for whatever level of injury. We are not going to get involved into the various different locations of spinal cord injury. That's not what NCLEX is about. We should not be asking you guys to identify, the client has a C4 injury. What do you expect? I'm not saying that they won't. What I'm saying is that is very patho. And what I would say is, because we know it's around the neck area, that your biggest issue is probably going to be airway. And you'll look at that as we go through these PowerPoint slides. So we do want to try to preserve as much function as possible. We're going to use the Glasgow Coma Scale. You can see it down there to kind of evaluate for changes or to trend any kind of changes. Then we're going to come back through and we're going to complete that full physical examination, the head to toe, look for any kind of spinal deformities, tenderness, bruising, and then we're going to look for bladder and bowel control issues, because a lot of these injuries are going to have complications. We're going to talk about two specifically. Neurogenic shock versus a autonomic dysreflexia, and what those are going to look like. And that's one of the reasons we're going to look at bowel and bladder. You have different types of spinal cord injuries, as primary or secondary. You guys are very familiar with those concepts. Then we're going to break it down into either complete or incomplete. So complete spinal cord injury, you have a total loss of motor and sensory function below the level of the injury. And then for an incomplete, you have some preservation of motor or sensory function. It may be diminished, but you still do have some. So once we start looking at our drawing on the right-hand side here, you can kind of see if you were to get kind of a question that resembled the client has a history at C4, what is the nurse's priority, or what does the nurse expect? You can see that you would kind of expect some tetraplegia, and that is basically from the C4 down. You know its body position, so you know what kind of expect from a motor or sensation kind of assessment. C6 down will result in partial paralysis of the hands and arms as well as the lower body. And again, because we see that we still do have or maintain some sort of function there at the shoulders. T6, so we've gone a long way now, right? So we're C6 to T6. You are looking at paraplegia, so right through here in this area. That's going to result in paralysis below that area of the chest. And then L4, you end up with paraplegia as well, and that's going to be below the waist. So if I were going to remember numbers, it would probably be these numbers, with injuries above C4 being the most imperative because of the involvement of the respiratory system. You have injuries that are going to be caused by either hyperflexion or hyperextension. If we're talking about just the mechanical movement of the spine, so hyperflexion injuries are caused by acceleration injuries. They produce a sharp snap forward of that spine, and you see these with head-on collisions, falls, divings. Hyperextension, so that process of that neck kind of going backwards. There's caused by rear end collisions or downward falls onto the chin. So you see here kind of on both of these what is happening both positionally and with the force pushing down on the top of the skulls. And you see that flexion of the spinal column and how it's buckling. I don't think hyperflexion or hyperextension would be on NCLEX. But lots of patient teaching. Risk factors, we know that it's men, and usually it's men who are involved in high-risk activities or participate in impact sports such as football, diving, high diving, acts of violence, gunshot, knife wounds. Usually alcohol or drugs can be a precipitating cause, as well as, for our geriatric clients, falls. So things that we would want to look for or ask about: pressure in the neck, back, head, intense back pain, maybe they fell down a flight of stairs and don't know it, any kind of paralysis or lack of coordination, any kind of unexplained weakness, lack of symmetry when we're moving our body parts, lack of sensation. We could have paresthesia, things that are twisted when we're going through and looking for those spinal deformities. Of course, there's the big airway breathing. What is the impaired breathing? Loss of control of the bladder or bowel. And then we've kind of talked already about the trouble walking or balancing. So again, this illustration is kind of breaking it down into that C4 and then below C4 to the thoracic region and then back into the lumbar regions, where we would expect to see signs and symptoms. We talked about with above C4, it's going to involve respiratory impairment. When we talked about the other, where you could still retain some movement, so that's that T6 through C5 kind of area here, you do see that you still have some sort of function of the arms. We said it was at the shoulders in that other picture, but it can extend downwards, and that's why we said limited range of motion. Then we talk about the rest of the thoracic and the paraplegic, loss of motor control, loss of sensation in the legs. So this just kind of breaks down what we expect. Tetraplegia, quadriplegia, basically the same things. Tetra is a newer term. So paralysis from the neck down. It usually involves the cervical spinal column, and the complications are going to vary depending on where that injury is located at. Paraplegia just means the lower two, so we're going to see loss of movement and sensation below that area of the injury. It's usually in the thoracic, lumbar or sacral segments of the spinal column. We keep hitting on this cervical injury information. Again, paralysis below the level of the injury, so that could lead to that tetraplegia. But again, breathing is our biggest piece here. When you're thinking thoracic injury, I want you to be thinking about the trunk for the body, and it's going to end up causing paraplegia. And then lumbar, I want you to think of legs and a leaky bladder. Those are our L's for lumbar injury. So we know that just based upon what information the NCLEX gives us, we can make a educated guess about what we would expect to see for signs and symptoms, or patient teaching too. There are many different types of spinal cord injuries. Usually when we say a complete spinal cord injury, we are talking about a total absence of movement sensation. Here we see this laundry list of these incomplete spinal cord injuries. I would not expect to see anything really drastic when we're talking about the spinal cord injury syndromes. So what I did was I went through and I highlighted the important information. So central cord syndrome, the left hand, all those bullet points underneath are more A and P-ish. When we go over to the manifestations, we know it's an incomplete injury, so there's weakness and sensory loss. But I would say central cord, you should know that it's related to mostly the upper extremities. So if the client is caring for, or the nurse is caring for a client with central cord syndrome, and the client asks about their long-term recovery, this is what I would expect to look at. Anterior cord syndrome, again, you see the A and P below that. And again, this one, it's anterior cord. You're going to have some injury, but because the posterior cord tracts are not injured, sensation, touch, position, vibration, or motion can remain intact. And then you just need to do your patient teaching about what it means if you have an anterior cord syndrome. Brown-Séquard syndrome, I remember this because it's two, so it's Brown-Séquard, and it's ipsilateral and contralateral. So ipsilateral, it's the same side injury. Contralateral, it's the opposite side injury. Posterior cord syndrome, so very rare condition. So I would expect that not a whole lot of questions on posterior cord syndrome from an NCLEX perspective. Then you have the conus and cauda, so the conus medullaris syndrome and the cauda equina syndrome. Yeah, it sounds like a horse for that one. They result in damage to the lower spinal cord and the lumbar and sacral nerve roots. Can cause flaccid paralysis, but again, we know because it's in the lower portion, it's going to be the lower extremities. But again, we see that the biggest one is this areflexia of the bladder and bowel. And that lines up, if you remember what we just did on the previous PowerPoint, lines up with exactly what we talked about with our L's, our bladder and with our bladder and our legs. I have not taught spinal cord in quite a while, so sorry. Again, we know we've talked about the expected diagnostic exams. MRIs are pretty much the gold standard. We're looking at the spinal cord. We're looking at the soft tissue damage. We can go and use CT scans, especially if we're looking at bony injuries. X-rays, EMGs, nerve conduction studies to see how well electricity is traveling down those myelin sheaths to allow us to see whether or not we are having a response. Medications. Okay, so lots and lots of different information out there right now about corticosteroids, specifically methylprednisolone. You can be administered within the first 8 hours post-op injury to help reduce inflammation. Some research is showing that it's not overly beneficial, but I would expect that you would probably see it used in some hospital settings because we do want to preserve as much as we can for their motor functions. So it's still out there. I think we all know with corticosteroids, be careful. They cause immunosuppression. They will affect your blood glucose, make it artificially elevated, things like that. Analgesics, you can either opioid, non-opioid. You can have this kind of phantom pain that is associated with, and it doesn't get relieved unless we are giving them analgesics. So you can have spinal pain, deformities that can lead to this kind of pain that we are experiencing. Our anti-spasticity agents, so baclofen, and that's going to be for muscle spasms. We want to decrease the number of muscle spasms to promote comfort. It's a basic care and comfort / pharmacology type of thing. Antidepressants, because as you can imagine, this is going to be very emotional for our clients. Anticholinergics. So typically when we're talking about an anticholinergic, we're talking about atropine. But notice we still have medications that end in the IN or the INE. These medications are going to be used for the management of neurogenic bladder. Unfortunately, we want to use them cautiously in our elderly clients because they can increase confusion, they can increase their risk for falls, they can impair their cognitive status, and they can also lead to urinary retention. So we may have to teach them to do either some intermittent catheterization or, making sure that we are not holding on to a lot in our bladder. Other diagnostic exams are just normal H&Ps. If you suspect respiratory issues, you can do ABGs, PFTs, monitor electrolytes, blood glucose, coagulation profiles, look at their hemoglobin hematocrit, get a UA, get duplex Doppler ultrasounds, right, and impedance. The plethysmography. Say that one 3 times fast. So any spinal cord injury, we're going back to look at what's expected. We can expect a lack of sensation, right? And the dermatomes, which is just a fancy way of saying the areas that transmit those signals below the level of the lesion or injury. And we want to teach the clients to report neck or back pain. We're going to teach them, and we can expect that they may have an inability to feel light touch. Usually they see that used with the cotton balls. The inability to discriminate between sharp and dull objects. You may be familiar with that because we do that for our stroke clients. So we can use a safety pin or sharp object. They may lack the ability to discriminate between hot and cold. We may see an absence of deep tendon reflexes. Obviously, if there's loss of sensation or motor function, you would expect that. Flaccidity of muscles, changes in blood pressure. And again, we're going to talk about shock, neurogenic shock, and autonomic dysreflexia. So hypotension that is more severe when the client is sitting in an upright position. Although, if my client is going to experience autonomic dysreflexia, we actually want them to sit up. Of course, shallow respirations, and then spinal shock, which we'll look at spinal shock versus neurogenic shock versus autonomic dysreflexia in a little bit. Respiratory complications, listen to lung sounds. We talked about the PFTs for that reduced lung capacity. Making sure that if they are at increased risk for aspirations, that we're doing the things that we need to be doing for that, have suction setup available. Cardiovascular, we're going to look at the shocks, the heart rates, the blood pressures. GI is neurogenic bowel and bladder, which we talk about later on. They can increase risk of constipation or fecal impaction, which may have to be removed manually. There's a huge risk for skin integrity complications because obviously they can't move themselves. We have to do that for them. So we want to teach them about changing positions every 2 hours in bed or every 1 hour in a wheelchair. Musculoskeletal, you have lots of issues with spastic muscles, contractures, potentials for pressure ulcers because of the lack of movement. Lots of teaching about the difference between complete and incomplete injuries. Lots of issues from a psychosocial kind of perspective, depression, anxiety, thermoregulation. Okay, so we can have issues where we are no longer able to control our own temperature, right? This can be caused partially because we have decreased ability to sweat or shiver below that area of the injury. So doing a good head-to-toe assessment and checking vital signs is going to be very beneficial. We may need to start nasogastric suctioning, which also has its problems because we know that can lead to metabolic alkalosis, decreased tissue perfusion. We want to measure, again, the electrolytes. If we are pulling stuff out of their gut, we know that that's going to have an extreme effect on their potassium. We've talked about neurogenic bowel. With constipation, we want to make sure that we're including a high fiber diet, adequate fluid intake. And again, our urinary complications, we talked about making sure that we are using intermittent catheterization if possible. And just looking at the overall collaborative care. So I see lots of questions over management of neurogenic bladder and neurogenic bowel, practice questions, NCLEX style questions, whatever. We talked about the use of anticholinergics. Look for medications that end in IN or INE. We can look for blood pressure medications. We can give antispasmodic medications. We want to make sure that we're managing the fluid intake, looking for issues with urinary drainage. So we may have to teach them about scheduling, restroom breaks. We talked about intermittent catheterization, or indwelling catheter, which of course we don't want to do long term because obviously that increases the risk for having an infection. So we talked about issues with neurogenic bowel and bladder. I want you to just recognize that urinary stasis is kind of common, and that allows for that calcium or the calculus to build up, and that's going to lead to significant injuries, including obstruction, which is going to promote infection, which in turn is going to compound the obstruction. So they give you a good little acronym over here. If you're looking at spinal cord injury, it's BLAME, it's bowel, bladder, limited range of motion below the area of the injury, changes in LOC, especially if they're going into some sort of shock or autonomic dysreflexia, or specifically related to medications. Again, we see changes in motor and sensation, and it can lead to extreme pain. All right, that's a lot of nice to know stuff. Let's get into the really good need to know stuff. So we've talked about immobilization, stabilization. This is the priority intervention early in the care of these clients, unless, again, it is a penetrating injury. We focus specifically on our airway, breathing, circulation, especially if it's C4 and above. We want to make sure that the client is adequately perfusing. All right, we want to try to maintain that PaO2 greater than 60. This always leads me back to the old respiratory, what we touch in respiratory with the 60-60 rule. So if I'm having to use 60% FiO2 to maintain a PaO2 of 60, then we're probably getting to start thinking of intubating those clients to maintain their respiratory status. And that leads us down to the intubation, if indicated by ABGs and PFTs. If we are having issues with management of our heart rate, blood pressure, you could still see the use of atropine, dopamine, dubodamine, whatever inotropic medication it may be. The goal here is a little different than it is for cardiac. We want to maintain that systolic blood pressure greater than 90, but that MAP, we want it to be artificially high because we want to make sure that we are perfusing the body as much as possible to promote health and to promote healing. And of course, one of the ways that we can do that is through the use of IV medications to maintain a blood pressure. We've talked about maybe insertion of an NG tube in suction and what to look for with those complications. And of course, the assessment and management of nutrition. So for our safety alert, you can see it says to use a hard cervical collar or a backboard to stabilize the neck to prevent lateral rotation. We don't want that to happen at all. The body should always, this is one of those words you should always look for, as always, right? Either in a good way or a bad way, be correctly aligned. Because again, you don't want any kind of twisting, turning changes. And we want to perform any kind of patient movement as a whole, as a unit. And again, that's just going to prevent flexion, extension of that spinal cord injury. It's going to make the injuries much worse. We want to do things to help regulate body temperature, up to and including bear huggers. Think about the possibility of indwelling urinary catheters or teaching about intermittent catheterization. We've talked about pain management. VTE prophylaxis is no different because the client is obviously not able to move around a whole lot. Do things to prevent pressure ulcers, stress ulcers. So we're probably going to expect to start them on a PPE or an H2 antagonist. We're going to talk about bowel and bladder care. And then mobilization, once we have them stabilized. Things to think about for long-term care was when we're looking at these: surgery, medications, traction, splints, braces, halos, and other support devices, an induced hypothermia. So we'll go through surgery. Is obviously very straightforward. We're going to go in, we're going to try to surgically repair whatever has happened to the either spinal cord or the bones surrounding the spinal cord. Right. So medications are going to be geared to maintain homeostasis, to decrease inflammation. Again, we talked about how corticosteroids are kind of hit or miss in the literature right now. We talked about traction. We're going to look at two types of different ways of providing support, either through the halo device or through tongs. And those are meant to provide stabilization and to make sure that we have enough, traction on that spinal cord to where it's going to be able to heal the way it should. And then induced hypothermia. This was a big one for me growing up. I was a Detroit Lions fan, and we had a player who went down with a spinal cord injury. That was a long time ago. But one of the things that we found through some of the services that he helped create after his spinal cord injury was more research into this induced hypothermia, just lowering the client's body temperature to decrease inflammation. So we're inducing hypothermia. But again, that's pretty high speed. So I thought this table did a good job of breaking down the emergency management of spinal cord injury. Again, it's not anything that we have not talked about before. It's just a nice way to break it down. So make sure you're looking at your respiratory function, your neurogenic function. So here we're going to talk about neurogenic shock. Just like with any shock, we talked about the changes in blood pressure, and then that's going to be made worse when the heart rate actually starts to fall. So hypotension and bradycardia, cool, clammy skin. We're going to look at spinal shock, which hopefully is just going to be a temporary condition. We talked about muscle weakness, paralysis, alterations in sensation, especially with temperature, numbness, paresthesia, pain, tenderness. Make sure we're teaching them about inspecting themselves, performing good bowel and bladder care, looking for methods to relieve urinary retention. Talk to them about maybe there's some issues with priapism or diminished rectal sphincter tone, so that's neurogenic bowel. Those are our assessment findings. Our interventions are going to reflect that. So make sure they have a patent airway. Maintain that SpO2 greater than 90%. Maintain the systolic blood pressure greater than 90. Make sure we have multiple IVs. We can start them on normal saline or LR to help with the blood pressure. We want to make sure that we immobilize and stabilize the cervical spine. So we're talking about the C spine stabilization. Make sure you're doing assessments for other injuries, any external or frank bleeding. We want to make sure that we're taking care of that and making sure that they're going out for appropriate diagnostic testing. We said CT, MRI. Ongoing monitoring, again, it's just coming back to what we've always talked about. Frequent vital signs, look for changes in LOC, changes in the SpO2, their cardiac rhythm, because we know hypoxia can lead to dysrhythmias, and then urinary output. So very similar to what we taught in cardiac. Anticipate the need for intubation, so if we see significant changes in the respiratory rate and function, and then make sure that we're doing things to promote normal body temperature. So complications. These are the big three that you'll see. Neurogenic shock requires immediate hemodynamic stabilization with fluids, vasopressors, and bradycardia management. We're going to make sure that we have frequent vital signs. This is where it's really important to maintain the MAP. Versus spinal shock, which is this kind of temporary loss of motor sensory or reflex function below the level of the injury caused by spinal cord trauma. This is usually because of the inflammation or the swelling or the damage. The key here is that it is a temporary, and although that we are saying shock, it's not really associated with extreme changes in vital signs. You are still going to have changes in vital signs, but it's more about the fact that this is a temporary loss of motor function. So when we looked at neurogenic shock, we said the blood pressure is going to go down and the heart rate is going to go down. This other piece, this autonomic dysreflexia, is basically a spinal cord injuries clients going into hypertensive crisis. Don't know why they don't call it hypertensive crisis. It's autonomic dysreflexia because it's related to the spinal cord. It is life-threatening. You're going to see extreme changes in the blood pressure. Usually, initially, that blood pressure is going to go up, right? And we are going to have to make sure that we are assessing for and treating the underlying cause. That is more important than treating with antihypertensive medications. If you treat the cause of the autonomic dysreflexia, we expect the blood pressure and heart rate to go back to baseline. If you don't, and you're just giving blood pressure medications, the stimulus for the high blood pressure is still there, right? If we don't, we're going to have severe complications like stroke. So autonomic dysreflexia, we see changes in blood pressure and heart rate, just like you would for shock, but it's more about an elevated blood pressure, whereas neurogenic shock is a true, I am not perfusing shock. So the key findings for spinal shock, we said it's a temporary loss, can last days to months. That's kind of temporary-ish. But the problem is that it can mask some of the actual long-term post-injury neurological function. So things I would be looking for: flaccid paralysis, loss of reflexes, loss of sensation, and again, we see absent bowel or bladder control. Monitor changes in LOC, make sure you're obtaining or maintaining a patent airway, make sure that we're maintaining immobilization of the spine. Monitor for the return of the reflexes. Teach the client to, hey, if you're starting to feel stuff, let us know. And then monitor your bowel and bladder. We've talked about steroids, we've talked about pain management and muscle relaxants. Neurogenic shock, when we're looking at it, what you would probably expect, it is probably going to be somewhere T6 or above. So if they were starting to talk about, issues below that, I don't have to really worry about neurogenic shock. It's not ruling it out. I'm just saying typically it's not something that we associate with. So T6 or higher, you still have the loss of control. That loss of the sympathetic nervous system causes peripheral vasodilation, venous pooling, decreased cardiac output. We want to monitor for the blood pressure, look for edema, look for changes in temperature. If they are sitting upright, you're going to put them, lower that head of the bed, put them down, because that's going to help bring their blood pressure back up. Key findings for neurogenic shock: hypotension, bradycardia, warm, dry skin, decreased perfusion to the organs, that's that target organ damage, decreased urinary output. So we're looking for the 3 Ds: decreased blood pressure, dependent edema, and dysregulation of the temperature. Maintain spinal immobilization. Try to keep the head of the bed to 30 degrees to prevent aspiration if possible. Provide fluids to elevate the blood pressure, atropine for bradycardia, and then monitor for signs and symptoms of autonomic dysreflexia, because this can quickly turn into that. Vasopressors, IV fluids, atropine, steroids, we've all talked about. Nothing really changes there. So autonomic dysreflexia is typically at or above T6 as well. So a sudden and severe hypertensive crisis, okay, extreme vasoconstriction, usually triggered by a stimuli, a noxious stimuli. So we see things that look for when we're talking about noxious stimuli is a full bladder, constipation, tight clothing, ingrown toenails, temperature extremes. So look for sudden severe hypertension, bradycardia, pounding headache is an answer that I see typically a lot on practice questions. Diaphoresis with this one. Nasal congestion is one of those other weird ones. So nasal congestion and piloerection, the goosebumps below the level of the injury. And of course, if you have those changes, you're going to have your normal changes with anxiety, blurred vision, feelings of impending doom, because this is a medical emergency. So now, instead of keeping the head of the bed lower, I want to raise the head of the bed, because that's going to help decrease the blood pressure. Immediately check for noxious stimuli. Do all the things that we've talked about. Make sure that we're notifying the healthcare provider. And then we can think about, once we've identified the noxious stimuli, we can think about giving antihypertensive medications such as your sodium nitroprusside or your hydralazine. Nitrates, hydralazine, blood pressure remains elevated. Lidocaine jelly for catheterization because we don't want to be a cause of noxious stimuli. Never really seen that in a test question, but and then of course we can use our alpha blockers or nifedipine to reduce blood pressure if repeated episodes occur. And I will say for the alpha blockers, if you've noticed, I don't go into a great detail about what your alpha blockers are. We're going to give them to lower blood pressure. So think about your medications that end in SIN. An alpha blocker is another way of lowering our blood pressure. A lot of the assessments are the same. Make sure you take a blood pressure and a heart rate before you administer. I'll give you prazosin, the mini press, or the doxazosin, Cardura, are common ones that you may see out there. But think also too that when we're looking at SIN medications, the tamsulosin Flomax that we actually don't give for blood pressure, we actually give it to help with other things as well, but it's still this alpha blocker type of medication. All those alpha blockers, you can expect orthostatic hypotension, you can have changes in dizziness, you can have issues with palpitations, weakness. It's still a medication being given to lower blood pressure. It's just not something I would expect to see a whole lot of on NCLEX. So here I wanted to go through and just break down the various differences between spinal shock, neurogenic shock, and autonomic dysreflexia. So complications, pressure ulcers for spinal shock, thrombophlebitis, DVTs, respiratory issues. Now you get into the bad words. Neurogenic shock is severe hypotension. That's going to lead to MODS, multi-organ dysfunction syndrome. And because it's a perfusion issue, obviously, it can lead to dysrhythmias, specifically cardiac arrest. And obviously you have issues because you're not perfusing for risk of hypothermia. And autonomic dysreflexia, because of the elevated blood pressure, you can have issues with either stroke or seizures. You can have MIs because of the lack of perfusion in the coronary arteries, and then again you see the organ damage from MODS. So things that I would again want to focus on: making sure that my client is perfusing, giving fluids, vasopressors, atropine, depending on what their blood pressure is, what their heart rate is. Make sure I monitor the airway. Make sure we think about positioning. When we talked about edema and PAD and PVD, it's kind of the same onus. We want to do things to prevent hypothermia because the client's no longer able to maintain it for themselves. And we want to do continuous monitoring of those vital signs and urinary outputs and bowel bladder. We talked about making sure that we're removing any noxious stimuli, making sure, again, we're looking at positioning while monitoring that blood pressure closely. We're going to teach them a lot about bladder and bowel routines, and again, frequent monitoring of the client and their vital signs. It's repetitive at this point, right? The last couple of things we're going to talk about are skeletal traction. You have these different tongs. Tongs and traction may be removed 1 to 4 weeks after the injury. We are placing pins in your skull, which can lead to infection. But they are going to help us stabilize the client's head. You see this in the picture here, that we're able to maintain that inline position. And you see, hopefully, that yellow bag over here on the right hand side in the picture, that's the weight that we're using to help us with that traction. Just make sure that we're doing preventative care. You're going to clean the site twice a day with normal saline and antibiotic ointment. Surgery and devices, surgical fusions and spinal stabilizations. Again, that's more geared towards the healthcare provider. If we're going to use a halo fixation apparatus, I'll show you a picture here in a minute. We know that that's going to be for a long term. We also need to be aware that the halo is the most frequently used method of stabilizing cervical injuries. All right, going to decrease their range of motion severely. We still have pins in the skull to keep that C-spine stabilization. We still want to monitor for issues with infection. We should teach them not to take showers, only sponge baths. We want to assess that pin site for any kind of infection, redness, warming, smelly drainage. Anything below that C6, the thoracic or lumbar spine injuries, can be immobilized by a body jacket, which is going to inhibit spinal flexation, extension, and rotation. For tongs and halo devices, again, just make sure they're maintaining body alignment, monitor skin integrity. Do not use the halo device to turn or move a client. You're not grabbing hold of it and turning the client. Again, this should be a log rolling issue for us, and we should probably be asking for help. Lots of patient teaching. For spinal surgery, usually we're going to see if we have some sort of issue with surgery. It's going to be related to the respiratory system itself. So following surgery, you're just doing the same normal frequent vital signs, frequent neuro assessments, but now we're also monitoring the surgery sites for infections, hemorrhage, hematomas, and again, observe for deviation of the trachea. We know that tracheal deviation is a medical emergency. We need to do patient teaching. They're going to be bedridden for a really long time. We don't really typically remove the rods unless they are causing pain. That removal won't happen until that spine has fully stabilized. And that's going to be, again, that's a question for a healthcare provider, not a nurse. So here kind of we see this therapy system. The RotoRest here is a turning system that we can use to help with our clients. Helps us turn them left or right. Helps us with the pillows, the blocks and wedges there to keep body alignment. You can see that we have inserted these brackets into their head to provide C-spine stabilization. On the right hand side you see the use of a sternal occipital mandibular immobilizer brace. It's another one that's tricky to say 3 times fast. Or the most common one, and by common you should know that that means basic nursing, is this halo vest. And that is really it for spinal cord injury. It's not a whole lot that deviates too far away. I would not get wrapped up into knowing a lot of the numbers unless we are specifically talking about that C4 and above. And then if they're coming back and they're saying things below that, then you know that it should be, the trunk for T and then the L for your legs and leaky bladder. Focus on a lot of safety. Your medications, knowing which medications are appropriate for a client, and I think you'll do fairly well on that section of spinal cord injury.